Lynn Chang is moderating this session. She is also on the Rome Foundation board, and she introduced herself.
Thanks, Cecile. So I'll be moderating this section, and we're going to be talking more about different aspects of pathophysiology and diagnosis and treatment of functional GI disorders, as well as talking really about patient-physician interaction as well. Oh, this is so big I can't see my slides. Wait, hold on. All right, so I'm going to talk about the pathophysiology of irritable bowel syndrome and other common functional GI disorders, but this is really a big topic, and I was trying to get it within 20 minutes. So I thought the best thing to do was to start talking about concepts and giving some examples of the functional GI disorders, but most of the research is done in IBS, so I'll cover that, but I threw in some data on functional dyspepsia and chronic constipation as well. Okay, so as you know, there's a whole range of functional GI disorders. This is just the category of functional bowel disorders, so it's really more within the abdominal region because they can differentiate according to where the location is in the GI tract. So functional bowel disorders, we have irritable bowel syndrome, functional bloating, functional constipation, functional diarrhea, and unspecified functional disorders. And as I said before, I'll probably focus more on IBS because there's more research, but I'll also talk about functional dyspepsia. So the pathophysiology in general is pretty complex, and if you look at the evolution of pathophysiology, it's really changed over the years, starting as considered a purely psychological disorder. There's probably people who still believe that, but in general it's more accepted that there is a biologic or physiologic mechanism or mechanisms underlying that, but it's a complex, and there's a series of factors that come together, and some are more important in some individuals and others are more important in other ones. But we know that patients with IBS in particular have diarrhea or constipation, so a lot of the research was done on looking at the motility of the bowel. What happened with that is that we found that not every patient with IBS had the same motility abnormality, and the motility abnormality didn't always correlate with symptoms. And then we recognize that these syndromes are associated with pain, chronic or recurrent. And so then the work went into understanding visceral hyperalgesia, so having a lower pain threshold to any type of visceral stimulus. And then we've really evolved into understanding that there's a brain-gut communication and there's interaction between the two, and that can drive the abnormal physiology or the perception of visceral stimuli in these individuals. And now we're moving into genetics, what the microbiota, what role they may be playing, and how the microbiota interact or communicate with the mucosal or epithelial cells, and how that may even signal up to the brain, and looking at neuroimmune interactions. But I think the way the pathophysiology is, like I said, it's multifactorial. We realize it's complex, and I think the challenge in seeing a patient is trying to recognize what factors you think are relevant in that particular individual. I think also the reason why you want to understand pathophysiology well is that when you're describing it to the patient, it needs to ring true to them. They want to understand it, and it's a challenge to actually put it in a lay language, but that's important, especially when you're trying to recommend treatment interventions, whether they're pharmacologic or non-pharmacologic, and patients, I think, will identify more with that at doing it or following that type of recommendation if they understand the rationale for instituting that treatment. So this is just a schematic of looking at the fact that we have some vulnerability factors that will make you more likely to have a functional GI disorders, and then there's also trigger factors that can bring on the symptoms or exacerbate the symptoms, and they can, range up from having a effect on the brain or the gut or both. And then if you look at the pathophysiologic mechanisms, the way I have divided it up is that you look at the role of the central nervous system, that the information the brain takes in from the body, the way it modulates and the way it now wants to respond through brain-body or brain-gut pathways can be altered in patients with chronic GI conditions. And then the brain-gut pathways are not just our sensory or pain inhibitory, pain facilitatory pathways, but we have the autonomic nervous system and the corticotropin releasing factor or the hypothalamic pituitary adrenal axis, and that can help communicate the brain and the gut as well, and that can be dysregulated. In fact, trying to develop treatments to act on that pathway, that has been in place. And then there's gut-related factors. Again, this is all bidirectional. It's a constant communication. But if we focus just on more in the periphery in the gut, there's There's abnormalities in serotonin signaling, so some of the agents we use for functional GI disorders are serotonergic agents. Again, studying the microbiota and understanding the role it plays in the pathophysiology of these conditions is important. Immune activation, and also now the hot area of intestinal permeability that's increased in patients with functional GI disorders, mainly in functional dyspepsia and irritable bowel syndrome so far. So I was going to try to review some of these. So if I always think of patients, what is the reason, or what could be a possible reason that they are more susceptible to developing irritable bowel syndrome or functional GI disorders? And that's what I try to get from their history. Well, one of the factors that can increase your chance of getting IBS is post-infectious IBS. So that means that you had no GI symptoms that resembled IBS. And there's even post-infectious functional dyspepsia. So you didn't have any of these GI symptoms to resemble these conditions, but then you got a gastroenteritis, and even though the infection has cleared, the patient will still now have symptoms of a chronic functional GI disorder like IBS or functional dyspepsia. And a lot of times in practice, those patients are treated over and over again, but they don't really have the infection anymore. It's not now they have this functional GI disorder. So this is just a systematic review that you may be familiar with that shows that your odds ratio of getting post-infectious IBS after having a GI infection is almost tenfold. Well, we want to look at what are the reasons for patients getting post-infectious IBS, and there's a number of reasons: having a very severe diarrheal illness, being a woman, being younger age, but also chronic stress at the time of your gastrointestinal infection is also a significant predictor of who gets that. And I think that just represents the importance of the brain-gut axis, and that the more, if it's dysregulated in some way, you're not able or capable of counteracting what insult you have to get it back in an equilibrium state. So if we extend that to chronic stress, and I see tertiary care referral patients, so they tend to be more of the moderate severe patients. So this tends to play more of a role in the patients that I see. So the way that we in our group, and our group, I forgot to tell you the name of our center, it's Center for Neurobiology of Stress, the way we conceptualize the role of chronic stress. So I'm talking about chronic, sustained stress. I mean, I live in Los Angeles, and driving in traffic is stressful. It is. You have to get used to it. I've gotten to the point that I use it as my relaxation time. I just kind of listen to music. I don't try to maneuver and try to find different ways of getting home faster because it's just stressful. But I'm talking about chronic sustained stress. And if you think about these individuals and you get their history, a lot of times there's probably a familial history, that there's a family history. So it may mean that's a genetic component. It could be also environmental, where they have some learned illness behavior. But a lot of times there's early adverse life events, or what we call early life trauma, where there's the death of a parent, or parental divorce, abuse, mental illness of a parent. So there's different types of early life trauma that individuals go through. And there have been studies to show that individuals who undergo that, they're more at risk. They don't have to be, but they're more at risk for developing chronic illnesses like obesity, asthma, arthritis, prescription drug use, recreational drug use. And there's also data to suggest that they're more at risk for IBS, for example. And I think that's because the body, the child, is trying to develop their adaptive, resilient systems like the neuroendocrine, behavioral, cardiovascular, immune system. And that develops up to age 18, if not older. The brain doesn't fully develop until age 25. And the last part of the brain that develops is the prefrontal cortex, where you have a lot of the inhibitory influence. So my kids aren't that age, but I'm waiting for them to get that age, so maybe they'll suppress some of that behavior they have. So you wait till age actually 25, and I think everything gets a little bit more suppressed at that time. But it just tells you how long it takes for us to develop and become more resilient. But so during that time, if there is a certain risk factor or trigger, either in a childhood or as an adult, it can trigger the onset of the symptoms. And what I find a lot in clinical practice, that once it's triggered, and it takes a lot to trigger a fairly healthy individual, it doesn't take that much to get an exacerbation once it has been set in motion. So that's something that I do tell patients, because I need them to know that. Now, even if that stressor is gone, the symptoms themselves perpetuate the symptoms, because you can have some anticipatory anxiety that's appropriate to have that can drive your symptoms. So Doug Drossman has done a lot of work on abuse, particular sexual, physical, and emotional abuse, and how that impacts the overall global outcome and the pain and disability in IBS patients. We did a recent study where we looked at all different types of trauma, and it basically shows that it's higher in IBS patients versus controls. And this ranges from general trauma to different forms of punishment or abuse. I always show this figure because I think it's important. There's a number of twin studies that show that identical twins, where you share 100% genetic material or information, you have a greater concordance of having IBS versus non-identical twins, which share 50% of genetic information. But what's interesting, so we know there's a genetic component, but what's interesting is that if you look at the mother and mothers who could have IBS if their child has it, whether it's dizygotic or monozygotic twins, it's very similar. So it just shows you that even though there is a genetic component, environment plays as much of a role, if not a stronger role. So it's always that interaction between nature and nurture, and that's what I also try to assess when I see patients. This is just to kind of put together that you can have stressors and dysregulation of your brain-gut axis, and it could lead to changes in GI function. So the classic chronic stress response of the GI tract is to have nausea and vomiting, probably from CRF2 receptors in the gut, and then to have frequent bowel movements or diarrhea through the CRF1 receptors in the distal colon. So that's a very typical type of response. There's also animal data to show that if you are under stress, you have increased intestinal permeability. So and also increased motility of the GI tract. So it just shows how the brain and the gut are very interrelated, and environmental factors or even physical factors will change the physiology and lead to symptoms that we see in our patients. So just to briefly go over the motor abnormalities. So for example, in functional dyspepsia, they have different motor abnormalities. The fundus of the stomach right here will not, it was not as accommodating to obtain food when it accepts food that we have eaten, so it becomes stiff. And the patients may develop a higher pressure within the stomach when they eat, so they get full more easily. There's also evidence that the antrum, or the distal part of the stomach, does not empty as well, so they could have delayed gastric emptying. But there's motor abnormalities within the upper gut that have been associated with functional dyspepsia. Also, there's evidence of dysmotility in the small bowel and the colon in irritable bowel syndrome. So, for example, in IBS with diarrhea patients will have more of exaggerated motor motility, and in IBS with constipation, they have less of these high amplitude contractions. This is just a study actually from Bill Che's father showing the power propulsion in the colon, that it's altered in patients with IBS, particularly the diarrhea type. So as you know, there's a gastrocolonic response. So you distend the stomach and it sends a visceral reflex to the distal colon, and it stimulates the colon to move. And that's why we go to the bathroom after a meal. And in patients with IBS, particularly the diarrhea type, that's very exaggerated. And so these patients tend to have more symptoms at that time, or have postprandial symptoms, but also even having bowel movements. Now, in functional constipation, that's patients with constipation symptoms, but not that much pain or no pain, just maybe some discomfort. The problem with those patients is the motility is altered. The problem with the colon motility is they don't have these high amplitude contractions to move stool through the colon so it can be evacuated. So they tend to have slower transit. So these are just some examples of motor abnormalities within these functional GI conditions. Okay, so we know that there's some motor abnormalities. We know that we don't have any motor abnormality to use as a biomarker to diagnose these patients, because they can have different types, so they all don't have the same finding. But as I mentioned before, there's enhanced perception or increased sensitivity in the gut that we see in these patients. So I'm just going to give you some examples. So there's two types of phenomena. There's hyperalgesia and allodynia, and you'll see them in your patients. So allodynia means that you are exposed to a non-painful stimulus, but the patient perceives it as painful. Hyperalgesia means that you are getting exposed to a painful stimulus that we would all consider painful, but the patient considered it much more intensely painful. So that's hyperalgesia and allodynia, and I think that these patients are really experiencing both. Now, we know that the sensations in the gut that you can see here, this is just an example of one of the studies we do, and Dr. Whitehead does that. We do that at UCLA, although we're trying to get away from it. It's hard to find patients to do this. But So you take a balloon and you inflate it in the rectum or the colon. It's connected to a computerized device, and you want to say, I only have 5 minutes left, but I have so much to talk about. Sorry, I've got to go faster. Okay, so you have some type of visceral stimuli. I am listening to Moki, so. And then this information, sensory information, is transmitted up these sensory afferent nerves to the dorsal horn neurons of the spinal cord, and they get repeatedly fired, and so the neurons themselves get activated. So it allows for all these signals to go up to the gut. And there's evidence in functional dyspepsia that they'll have these symptoms that you can see on the x-axis at a lower volume of a balloon placed in the stomach compared to a healthy population. You'll also see evidence in IBS. They'll either have a lowered pain threshold, so they'll feel pain at a lower pressure in the rectum, say 30 millimeters of mercury instead of 40 millimeters of mercury. They'll also have higher ratings to those distensions. So it's evidence that they have hypersensitivity. And pain and bloating are the two symptoms that have been associated with this visceral hypersensitivity. So it's thought that perhaps, at least in the periphery, that there may be mediators that are acting on these receptors of these sensory afferent nerves and causing them to fire more likely, such as bradykinin, histamine, or tryptase that's released from mast cells. So some people are starting to look now at inflammatory cells or immune cells within the mucosa of the small bowel and the colon, like in this functional dyspepsia study where it showed that mast cells were increased, but more in the IBS group than the functional dyspepsia group, but there was more eosinophils in the duodenum in functional dyspepsia patients versus controls. And there's also data, like you can see on the left side, where there's more mast cells in the colon in some patients with IBS, or decrease anti-inflammatory cytokines in IBS patients. Again, that's just in a subgroup of patients. So could these immune cells be activated, release these protease or tryptase or other types of mediators that activate the sensory nerves and cause them off more firing? So that information is transmitted up to the brain where we can consciously perceive it, which many of the sensations we shouldn't be feeling. There's evidence in brain activation patterns that there's similar areas of the brain that are activated in controls and IBS, but there are different areas, and some of those areas are areas that receive information from the body. There's circuitry that's involved in trying to modulate that information and activate pain inhibitory pathways, and that circuitry is altered, so they're not able to counter-regulate the information it receives from the body. So we have these descending pathways like the opioidergic, the noradrenergic, and serotonergic that may not be activating sufficiently to counteract the stimuli that the body is experiencing. And then there's other pathophysiologic mechanisms more tied in the gut, although again there's brain-gut signaling that may play a role, like the intestinal permeability, which I'll have to skip through, but there is some evidence that subgroups of IBS patients will have evidence of increased permeability, and I think patients are calling, at least in California, they call it leaky gut. That's a very common complementary alternative medicine term. And this is too complicated, but there's a study on the left side in children and a study on the right side in adults with IBS, and basically showing that in some patients the microbiota that's obtained in the fecal samples is different in these patients than in healthy controls, and I think we have to learn more about that. But we know bacteria plays a role in generating gas, and so some of the medications that we use help to change that dysbiosis, but abdominal bloating is not just have to do with bacteria. It also has to do with the fact that we sense what's going on in the gut more. We feel that it's bloating. We have contraction of our diaphragm, relaxation of the abdominal wall muscle, and then we get distension. So to summarize the pathophysiology of functional GI disorders, they're really best viewed as a biopsychosocial disorder where you have this dysregulation between brain-gut or neuroenteric systems, and they're influenced by central stimuli as well as enteric stressors like food or other type of stimuli like an infection. There's an interaction between genetic and environmental factors. I think that's important, and that does play a role in increasing the susceptibility of getting these and plays a pathophysiological role more likely, but although we need more information. And then to think that separate from these increased vulnerability or susceptibility factors, there's also triggers that just trigger the symptoms even after they have the condition, like stress, infection, and food, as I mentioned. Functional dyspepsia in IBS patients as well as chronic constipation do show abnormalities in the GI tract for the motor abnormalities. For chronic constipation, it's not so much a hypersensitivity as we see in functional dyspepsia and in IBS. And then modulating these brain-gut pathways with either psychologic, behavioral, and biologic processes result in having physiologic alterations in gut motility and visceral perception. So hopefully targeting both centrally and peripherally will be helpful to treat these patients. Thank you very much for your attention.